Hi, I'm Jared Gardner, and today we are going to be discussing Myxofibrosarcoma. So this is one of those tumors that's confusing because there's another soft tissue entity that sounds very similar, and that's low-grade fibromyxoid sarcoma. So it's really important to not confuse those two. The names sound similar, but they're totally unrelated and very, very different tumors. They're actually quite easy to tell apart, and I'll have another short video to quickly discuss the ways to distinguish myxofibrosarcoma, what we're talking about here, from low-grade fibromyxoid sarcoma. Myxofibrosarcomas are pleomorphic sarcomas. They're run a range from low grade to intermediate grade all the way up to high grade. At the high grade end, they have areas that resemble undifferentiated pleomorphic sarcoma. And they probably represent, at least the high grade ones, I think probably represent a myxoid variation of undifferentiated pleomorphic sarcoma. And I'm going to tell you the features here. These are, all sarcomas are rare compared to other types of usual cancers like carcinomas. But among sarcomas, myxofibrosarcoma is one of the more common ones, at least in my practice. I see these on a regular basis, usually a couple times a month at least. In routine sarcoma service work. So a few things. They usually occur in elderly patients. They're in older adults, very, very rare in young adults, and I've personally never seen a case in a child. There are some reports in the literature, although I still remain skeptical a little bit about those. I just have a hard time understanding how it occurs in a young patient. So it usually is older adults. The lower extremity is the most common site, but also you can see it on the upper extremities or other places. But usually the lower extremities of elderly patients. They are oftentimes in deep soft tissue, but another unusual thing about these tumors compared to other sarcomas is that they tend to involve the suprafascial, the superficial soft tissue above the fascia layer. So the subcutis and the dermis, about half of cases go above the fascia up into the subcutis or the dermis. So that's important to know. And the other thing is many sarcomas, in deep soft tissue at least, are very round and circumscribed. They grow quickly, they push other tissue out of the way. But as you can see here, this tumor is very, very infiltrative. Look, it's splaying apart these skeletal muscle bundles and infiltrating into the soft tissue beyond. And because of that, they tend to extend much farther than it appears clinically. They tend to extend out. If it looks like a 3-centimeter mass on the skin of the thigh, once the surgeon takes it out, they may think they'll have wide margins around it, but the tumor's often going to extend out to the margins even when the surgeon thinks that they've gotten around it. And so that's a problematic thing. And if you don't clear these tumors because of their infiltrative growth, they have a high risk for local recurrence, okay? So let's talk about the histologic features. We've covered some of the clinical information that's really pertinent and important to know. First of all, these tumors, as the name suggests, they are myxoid. They have a bluish background and areas that are hypocellular like this, okay? The low-grade forms are almost entirely hypocellular with blue myxoid background. At the high-grade end, you might only have small pockets of myxoid stuff, and most of the rest of the tumor will be sheets of high-grade pleomorphic sarcoma. So the myxoid change is abundant. And I think that's one helpful way to remember myxofibrosarcoma. The word myxo comes before fibro. They usually look more blue than pink, as opposed to low-grade fibromyxoid sarcoma, which the fibro word comes before myxo. They look usually more fibrous and pink and less myxoid in general. There are exceptions to the rule, of course. And one thing you can begin to appreciate, we're on 4x objective here. Already you can see big, hyperchromatic, pleomorphic cells scattered in the background. That is basically the hallmark feature of this tumor. To make a diagnosis of myxofibrosarcoma, you essentially always have to have hyperchromatic, pleomorphic, atypical cells, at least some scattered. Even in the grade 1 low-grade form, there should be pleomorphism and nuclear atypia. And the pleomorphism is a sign of what's going on molecularly. These tumors, like almost all other pleomorphic sarcomas, they have random chromosomal gains and losses. They don't have any recurrent translocation. Translocation sarcomas usually have uniform, monotonous cells, and aneuploid tumors that have random gains and losses usually have pleomorphism. Some of the daughter cells are small, some are big, so you'll see atypical mitoses and pleomorphic cells. That's true for most pleomorphic adult sarcomas. So here you can see these big, ugly, nasty, hyperchromatic pleomorphic cells. No one, even a medical student, will look at this and say, I think that cell's atypical, right? And it's because it's so ugly and so much bigger and nastier looking than its neighbors. But even the background cells that are smaller, you can still appreciate, really have a lot of hyperchromasia, very atypical nuclei. And the tumor cells are floating around in this background of blue ground substance, myxoid material, hyaluronic acid, and other glycosaminoglycans in the background here. So that's a very characteristic thing. Ugly tumor cells floating in a myxoid background. Okay? The other feature that you often see in myxofibrosarcoma are these blood vessels. Look at how prominent the vascular network is. And the vessels tend to be long, and they kind of gently undulate, or are kind of curvy linear. They're long and kind of slightly wavy. You can imagine this vessel probably goes a lot longer than we're seeing, but see how it goes up and down. It's this kind of curvy, oh, I don't have it quite on the screen here. Here we go. This one, you can see it's going up and down, this kind of curvy, linear, elongated vessels. So that's a very characteristic feature of myxofibrosarcoma as well. And like I mentioned, look at the tumor infiltrating out here. It's clearly splaying apart the muscle. And you can easily tell that's tumor, not just reactive myxoid change in the soft tissue. That's tumor. That's still tumor. Now it's infiltrated beyond the muscle and out into the fat. And we see normal blood vessels in the background. Still see tumor cells in there. And the tumor will go all the way out, and it's probably positive out at the margin somewhere. So again, this is a very characteristic finding on imaging, at least if imaging studies are done for the deeper soft tissue masses, when myxofibrosarcoma is a large, deep mass. If they've done an MRI or CT, you often can see these strands of tumor extending out from the main tumor mass and in between the fascia, in between the muscle, along the septa, along the subcutaneous septa, and along the fascia layer that divides the subcutis from the skeletal muscle underneath. So there's a nice example again of those very prominent elongated vessels. Now sometimes you can see a little bit of delicate vessels that are a little branching. Don't confuse this with a myxoid liposarcoma. No way is this going to be a myxoid liposarcoma. The reason is myxoid liposarcomas, they do have myxoid change, they are hypocellular, they do have delicate branching vessels, but they rarely ever have pleomorphism, again because they're translocation associated sarcomas. So when you see big ugly cells in a myxoid tumor, you are almost certainly not dealing with a myxoid liposarcoma. Even the high-grade round cell form of myxoid liposarcoma still has relatively uniform cells. They're round and they all look like each other because they have the same molecular abnormality. This tumor, again, has random gains and losses. Here's another important point that is often seen in myxofibrosarcoma. Look at this cell right here. Let's see if we can get him back on the screen. Now this cell is very pleomorphic, but it has bubbly cytoplasm, and you might be tempted to think that it could be a pleomorphic lipoblast. Now, pleomorphic lipoblast are not seen in myxoid liposarcoma, but they are seen in pleomorphic liposarcoma and occasionally in dedifferentiated liposarcoma. We'll talk about that in another video. But this is not a lipoblast. This is a pseudo lipoblast, and it's a common finding in myxofibrosarcoma, and you can also see it in other types of sarcomas that have prominent myxoid background. What's happening here is the tumor cell is sucking up the background myxoid material. It's eating it up, and it's making vesicles filled with that same bluish myxoid material. See how this is blue and myxoid? The inside contents of each of these vacuoles is blue and myxoid, just like the background. That's the easiest way to tell this apart. Lipoblast should have totally clear, white-looking vacuoles because they're empty. They were filled with lipid. During processing, the lipid washes away and dissolves during tissue processing, and what's left behind is an artifactual space, a round circle that often indents the nucleus. Pseudolipoblasts, on the other hand, the vacuoles usually are not perfectly round because they weren't lipid. Lipid has to be a spherical shape in aqueous solution. Our bodies are made of water, so lipid droplets make bubbles. Look at adipocytes, look at sebaceous cells, look at true lipoblasts. They all have perfectly round little bubbles that are white and washed out and have nothing inside them. So a true lipid droplet should do that, whereas myxoid material that's been sucked up and eaten by a tumor cell will make these kind of loose, irregular, floppy-looking vesicles or vacuoles in the cytoplasm. It'll have a bluish color. It may sometimes indent the nucleus, but it won't be that sharp scalloping that you usually see in a lipoblast most of the time. See, there's maybe a little exception down here. There's a little indentation of a nucleus here. But so see, the main thing to me that helps is just recognizing that there's blue stuff inside the vesicle. That's not a lipoblast then. That's a pseudo-lipoblast, and it should make you think of myxofibrosarcoma, also myxo-inflammatory fibroblastic sarcoma, a much more rare and unusual tumor we'll have to talk about in a different video. Look, here's another one. Two other ones. This one is, you can see the tumor nucleus over here. Maybe this is a next door neighbor nucleus. Lots of bubbles here. All of them are blue. Here's a tumor. Oh, that looks maybe like it's clear and indenting the nucleus, but look right next to it, blue stuff. So again, these are pseudolipoblast. This is a very common feature in myxofibrosarcoma. Let's look at a few more cases. Now, here's an example in the skin. And like I said, these I also do dermatopathology in addition to sarcoma pathology. And I think this is a really important tumor for dermatologists and dermatopathologists to know about, because they will often, when they get into the skin, they can be kind of small, only a few centimeters. They may look like a cyst or a lipoma, which is a common thing. Many sarcomas and other rare malignancies like malignant sweat gland tumors, things like that occur in the skin, they're deep to the epidermis, and so they often get misdiagnosed clinically as a lipoma or just a cyst, because they look like a skin-colored nodule, like a cyst would look like. And cysts are much more common than sarcomas, so it's understandable how this happens. But it's important to remember that they can sometimes get be thought to be benign clinically, and then once the dermatologist or the surgeon removes the lesion, it becomes clear that it's not a cyst, and then it gets sent in for consultation, and I end up seeing them. So this is one here. You can see it's involving the dermis. And this is a very hypocellular case. So a case like this, I would probably call, based on this area here, I would call this a grade 1. And you could also say it's a low-grade myxofibrosarcoma, but I really hate doing that, even though it's technically correct, because it sounds so much like low-grade fibromyxoid sarcoma, which is incredibly confusing for everyone else except for soft tissue pathologists. So what I like to do is say myxofibrosarcoma, comma, grade 1. And that helps to distinguish that, by the way the name is written out, to help people distinguish that this is not low-grade fibromyxoid sarcoma. This is myxofibrosarcoma, that is low-grade. And again, the key, it's hypocellular. You could even think it might be a myxoma, but even from this power, you can see big hyperchromatic cells floating around in here. Myxomas, benign myxomas, should never have hyperchromatic, ugly cells floating around, at least not in my experience. So again, you can see here the background of myxoid stuff. Sometimes we get artifactual little bubbles in the myxoid material. I don't always see this, it just sometimes happens on processing, but you can clearly see the tumor cells are hyperchromatic and pleomorphic, very atypical. Mitoses, if you look around, mitoses are usually present, they're often atypical, but in a hypocellular grade 1 lesion like this, the mitoses may be infrequent or hard to find. But you've got ugly pleomorphic cells, and they're floating in a myxoid background. If you look around, we'll probably find vessels. You can see some elongated vessels in here. And the vessels, these are delicate, but a lot of times they're thicker and bigger than the vessels of, say, a myxoid liposarcoma. But again, you don't have to worry about that because you've already got the pleomorphism. Myxoid liposarcoma is almost never going to have pleomorphism. Look at those beautiful pseudolipoblasts there. Sorry, I know beautiful isn't a great term to apply to sarcoma, but those are a really great example of tumor cells that have sucked up and eaten a lot of that myxoid bluish stuff. And even though they look bubbly, if you look closely, at least on my scope, you can see they have a bluish color. They're not true lipoblasts. All right, and then let's go back to lower power here, and look, we got one nodule here, but look, and it's infiltrating up into the dermis, but look what it's doing in the subcutis. Remember, the subcutis is made of mature adipose tissue arranged in lobules. The lobules are divided by thin, fibrous septa. And we often, in normal subcutis and skin, we don't often see those septa very well, but in pathologic processes, whether reactive or inflammatory or tumoral, we often can see the subcutaneous septa highlighted more clearly. All right, and look what's happening here. You can see the septa is very widened. Here's one fat lobule, here's another one, and look, here is fibrous tissue expanding that lobule, but look, expanding that septum, and look closer though. ugly hyperchromatic tumor cells are in the middle there. They're infiltrating between the fat, and look where they're going. Down here, you can still see tumor going along here. There's still more tumor. We're way away from the main tumor mass, and we're coming all the way out to the inked margin here, and we still have tumor cells. So grossly, it would sometimes be hard to see these subtle areas of infiltration. Certainly, it's going to be hard even for experienced sarcoma surgeons to detect these. I work with some really awesome sarcoma surgeons, and there's still times that they're surprised when the margins are positive because they really thought they were around it in the operating room. And again, this is because the tumor is sneaky and infiltrative, not because the surgeon doesn't have the skill to recognize it. It's just these are hard tumors to see the edges of, and you have to plan accordingly. So I usually add comments to my report when I diagnose this tumor that they are often very infiltrative, they're often hard to clear surgically, you have to really get around them with a wide margin, and you should follow these patients because they do have a higher risk of local recurrence, okay? So this is a great example. Again, here's the main kind of tumor mass over here, and it's infiltrating all the way out here along the fascia and in between the subcutaneous lobules on the septa. Okay. Here's another example in the skin. Again, look at that infiltrative growth. I always worry about what will happen if I ever get a superficial biopsy of one of these. So if I see on the extremity of an older person, if I see anything myxoid and with atypia in the dermis, I like to usually add a comment that, you know, make sure that to the dermatologist to make sure that this is not part of a bigger, deeper mass, because it could be a superficially sampled myxofibrosarcoma in that setting. And again, you can see the pleomorphic cells, the elongated, there's the cells, lots of them. Here's the elongated vessels, the myxoid backgrounds. And down here, though, it becomes much, much more cellular, and you have stuff that starts to resemble what you'd see in an undifferentiated pleomorphic sarcoma. Here we just have cellular sheets of pleomorphic, very ugly tumor cells. So in an area like this, I would just call this an undifferentiated pleomorphic sarcoma if this was all I had and I had done stains and they were negative for the usual markers. But out here, you see it transition into areas that are becoming less cellular, more myxoid, long, elongated, curvilinear vessels. Look, here's an atypical mitosis. I told you usually will see those. If I can get it back on the screen. There it is. Atypical mitotic figure. So I would call this a myxofibrosarcoma high grade or grade 3. And occasionally you'll have some that are kind of in between and you call them grade 2. That the exact grading of myxofibrosarcoma can be a little bit tricky and subjective, and so not everyone does it quite the same way. To me, the most important thing is recognizing the ones that are totally hypocellular and don't have any cellular areas. If I start to see any areas where the cells are really clumping together like this, then to me it's at least a grade 2. If it's large areas like this, then it'd be a grade 3. That's the way I do it. And both grade 2 and grade 3, in my opinion, should be regarded as high-grade sarcomas with metastatic potential. The risk of metastasis is actually a little bit less in some studies than for, say, other pleomorphic sarcomas like an undifferentiated pleomorphic sarcoma, but they still have full-blown metastatic potential, and again, the local recurrence is a much more common issue here than with a lot of other sarcomas. The low-grade, grade 1 myxofibrosarcomas, when they are confined to the subcutis and skin and they're just grade 1, they almost never metastasize. So I think it's important to distinguish those very hypocellular grade 1 examples, like here's an example here. Here's a nodule in the subcutis. It's small, it looks hypocellular and myxoid. You could think, certainly from low power, you could wonder about, is this a myxoma? But once we get closer, even though it's not very cellular, it is very pleomorphic, very hyperchromatic. The nuclei of myxoma are small, kind of bean-shaped nuclei. They usually have pale chromatin. These guys are ugly. Sometimes you'll get multinucleated hyperchromatic cells. Sometimes it's hard to get the nuclear detail to show up on the video, but you can see how hyperchromatic and ugly these cells look. So even though they're scattered, If I see something that looks like a myxoma and it's got scattered, ugly pleomorphic cells, then it's probably a myxofibrosarcoma. One important pitfall to avoid is that, particularly for intramuscular myxomas, they can entrap skeletal muscle. That's a common finding. And when skeletal muscle fibers get atrophic, the nuclei clump on top of each other and can mimic pleomorphism. So you want to make sure that you're not making that mistake and overcalling entrapped atrophic skeletal muscle as pleomorphism in a intramuscular myxoma. But in this case, we have a myxoid lesion that's hypocellular but has scattered pleomorphism and it's in the subcutis. I'd call this myxofibrosarcoma, grade 1. Now, for a lesion like this that's grade 1 and confined to the subcutis or the dermis, the chance of metastasis, again, is close to 0 probably. The problem is, though, that local recurrence is still a big issue, even for the grade 1 examples. And sometimes when these tumors recur, they tend to recur as a higher grade. So I've seen cases that started out as a low grade, and when they recurred, they had more and more cellular and more atypical areas, and eventually became full-blown high-grade myxofibrosarcomas. So that's an important thing to remember when you're looking at these cases. Here's another example here, and this is one that I might think about putting in like a grade 2 if I just had areas like this. Much of it looks like the grade 1, hypocellular, long vessels, ugly cells. And the ugly pleomorphic cells have this tendency to kind of clump and cluster around the edges of vessels. See how they're kind of making these clusters around the vessels here? And then you can begin to see areas where those clusters expand. So you might call something like this a grade 2 or an intermediate grade. And especially when I just have a fragmented partial specimen, if I see one of these and I think it's got cellular areas but it's not quite enough to call grade 3, I'll usually say myxofibrosarcoma at least grade 2, and then put a comment that, you know, obviously this is a fragmented specimen. This was probably taken out assuming the lesion was benign. That's what usually happens in this kind of a case. And then I'll make the comment that there's probably a lot more tumor left in the patient. They need to do a wide local excision and then examine that wide local excision specimen to see if there are any other higher grade areas present before making a final grading assessment on this tumor. Here's one more case, again showing the variability running from very hypocellular areas like this to more and more cellular areas, and eventually sheet-like areas that look like other high-grade pleomorphic sarcomas. But even still, even when you have the high-grade form, there's usually going to be little pockets of myxoid material, and that's going to be one clue that you're probably dealing with a myxofibrosarcoma. So if I see sheets of high-grade pleomorphic spindle cells, and I see pockets of myxoid stuff like this, if I see some prominent curved linear vessels, those things make me suspect I'm dealing, like if I have that right there, to me this, if I had even only a little areas like this, I would still call it a high grade or a grade 3 myxofibrosarcoma. To me, even an area like that is enough. There's not a good standard in the literature. Again, it's kind of subjective, but if I start seeing even pockets like this, it's, in my experience, these usually end up on full excision being a myxofibrosarcoma. And again, the reason that's important is to make sure that the surgeon's aware of the infiltrative nature and the potential for local recurrence. And again, in this case, you can see it infiltrates out into the skeletal muscle and beyond. And I think the heterogeneity, this is true of many myxoid tumors. They tend to be heterogeneous. They can have more cellular and less cellular areas, and this is particularly true of myxofibrosarcoma. And the way I kind of think of it, I don't think this is biologically what's happening, but there's all this myxoid gooey stuff in there, and the tumor cells are floating around in it, and sometimes they float around and they clump up at one area. Like if you have a bunch of, driftwood or debris floating on top of a lake, sometimes the wind blows it all to one side, and so you'll get an area with very little debris, and then an area over here where it's like a log jam and everything's all packed together at one end of the lake. So in my mind, I kind of use that as a memory device. And I think it's the same kind of concept too when I think about the infiltrative potential. I feel like the myxoid stuff oozes out of the main tumor, and then the tumor cells kind of come along with it. And that's part of why it has this very infiltrative kind of leading edge. And even in intramuscular myxomas, which again are unrelated, but they have a bunch of myxoid background, you can see that same thing where you can have a lot of myxoid material oozing out and in between the adjacent skeletal muscle. So I feel like myxoid tumors have something about the myxoid background gives the tumor cells this ability to spread out out into the adjacent tissue. And here, look at this curvilinear vessel. Here's a really prominent one that runs from here all the way up. It's like the Grand Canyon. It just continues to go and go and go and branching off in different directions. So these very prominent elongated curvilinear vessels are a classic feature of myxofibrosarcoma. Just a couple more cases and then we'll finish here. I think we've covered the details again and again, but sometimes repetition is a good thing. Here's one again. Look at how blue. I mean, from low power, you could even almost wonder if this is a chondrosarcoma or something, a cartilaginous tumor, because it's so blue. Myxoid material and chondroid material can look quite similar. But here we've got tumor cells, very ugly, some that are multinucleated. They're floating around in the myxoid background. And again, look at their cytoplasm. Many of them have phagocytosed. They're sucked up and eaten the bluish myxoid material from the background. So those are all pseudo lipoblasts. Some of them look more bubbly than others. And if you do a stain for the myxoid background material, like an Alcian blue or something, you can usually really highlight this stuff, but you don't need to because it's so obvious on H&E. But it is pretty, so if you want to do something for educational purposes, that's a kind of a fun thing to do. And then look over here. Very, very wild, nasty atypia. Very ugly cells. More pseudolipoblasts with the myxoid gooey bubbles inside their cytoplasm. Another myxofibrosarcoma. So I think that pretty much covers it. Keep this entity in mind. It's a really important disease to know about. You will probably encounter these in your practice at least at some point. And there are other tumors that are sarcomas that can have a myxoid background, and it's important to not confuse myxofibrosarcoma with those because it's kind of a unique tumor that has some very important points that need to be considered both clinically and histologically. I hope this video has helped you understand it. And again, if you haven't watched my low-grade fibromyxoid sarcoma versus myxofibrosarcoma video, I encourage you to do that. I'll put a link in the video description down below. Thanks for watching. Click like if you enjoyed the video, and please subscribe to my channel to get updates about more derm path and sarcoma videos in the future.